Good afternoon. I'm taking a slightly different view of big data than the most, I think, talks given here today. I'm from industrial engineering, and in industrial engineering, I'm actually at a fairly specific sub-area which deals with modeling human decision processes with economic, psychological, and operations research models in order to optimize system design. Now, I'm very interested in medical issues as well for quite some time. And in this context, I'm wondering what actually having big data will do to medical practice and clinical outcomes. Now, obviously, once we have medical data and we have large bodies of these data, we can infer all kinds of things. And now the current use of computers makes accumulating these large quantities of data possible. Now, we obviously have large potential benefits. First of all, one thing we can now easily do is decide or know what happened to a patient in the past. We have access to his or her entire medical record, and we can look at, for instance, actions other physicians did with respect to this patient. So one of the major issues when we coordinate, for instance, the care of complicated patients who are in the care of a number of specialists. Another issue that is possible now we have big data is we can look at clinical outcomes or in clinical histories of large numbers of patients who receive different treatments and use this information to make decisions. So instead of using peer-reviewed research as the basis for evidence-based medicine, we can actually look at all cases of patients who have similar background to the patient we are trying to treat at the moment and see what outcomes we had. Now, this is obviously very, very promising. But could there also be some negative consequences? Now, one issue that may come up and that you perhaps sort of thought of when we heard, for instance, this wonderful talk about Trito, this web-based system, is that when we access large bodies of data, we may reach conclusions that are characterized by the properties of this particular data. For instance, in Trito, we may have lots of patient recommendations, thousands of patient recommendations talking about the great use of astrological charts for diagnosing certain problems, okay, because they just report these things. So similar biases, maybe less extreme ones, are also possible when we have clinical data that we access directly and not through the peer review process. But I would like to talk about a slightly different problem that might arise when we have big data. Now, the problem I want to address is related to collecting data on hospitalized patients. We now have monitoring, continuous monitoring of patients in the ICU and in surgery, and we are very likely to have large-scale data collection also on hospitalized patients not in the ICU. Okay? In other words, once we have, for instance, wearable sensors. Now, currently, these data are accumulated and they are stored at the ward, or they're not accumulated at all. They're just used on a moment-to-moment basis. But we can think of the option of adding monitor data to a patient's electronic clinical record. This would allow us now to look at what exactly happened to this patient while he or she were in the ICU. Now, obviously, again, this has clear advantages. Okay? I have the detailed history of the patient's hospitalization. I know exactly when certain things happened. And perhaps I can even understand certain clinical developments better. The patient had a seizure at a certain moment in time, and I can look at the record and see what preceded this seizure. So this is certainly something that is very promising in principle. But could there also be some negative effects of having these data stored? Now, to understand a possible negative effect, let me tell you about a story we did some time ago already. But I think the results are still valid as far as I know from talking to physicians and reading the literature. What we did, we looked at nurses' responses to alarms in a neonatal intensive care unit. We hooked up to the monitors in the unit and collected any information we had in the unit. And we placed observer students in the unit who sort of had to write down whenever a nurse approached an infant and performed some action. And we were interested in tying nurses' actions to information they received from the monitors. Now, as everybody who ever visited an ICU knows, there are lots of alarms, especially in neonatal intensive care units. We actually had something like 16 or 17 alarms per hour, which means about every 4 minutes on average there would be an alarm. When we looked at what nurses did, and we coded it by asking what's the probability of a nurse approaching a certain infant within a 60-second time window after an alarm had sounded from the monitor of this particular infant. What we found is that nurses, by and large, did not go to infants. So we had smaller or shorter alarms and longer alarms, and we find that among the longer alarms, 5 seconds and longer, less than 20% of the cases, when we had a cardiac alarm, the nurse went to the infant. In 40% of the cases, when there was a respiratory alarm, the nurse went to the patient. And in about 20%, when we had a pulse oximeter alarm, the nurse went to the patient. Now, there may be the gut response that says we have a problem. The nurses are doing something wrong. Okay? There is an alarm. Obviously, what we immediately want them to do is go and treat the patient. But perhaps this may be a little bit a simplistic view of matters. Perhaps this is not a problem. Perhaps the nurses are actually doing the right thing. What do we see? We see that alarms are very frequent. Okay? About every 4 minutes or so, we have an alarm. And we also know that alarms, in our particular case, were rarely justified. We observed the nurses in this particular study for about 50 hours, and we had not a single case of mortality, of death, or of an extreme adverse event for one of the patients there. So eventually we had lots of alarms, but nothing really bad happened. So actually, perhaps nurses attending whenever there was an alarm may have had some negative consequences. One main problem we have in intensive care units, and especially in neonatal intensive care units, are infections. And a nurse interrupting treating one patient and going to another patient to see that there is an alarm and there's really nothing happening, all she needed to do is attach a sensor, may actually increase the chances of transmitting some pathogen from one kid to another, or for increasing the chances of infection of the kid she just left behind. Also, when I interrupt an action and I do something else and I have to resume the action, it's likely that I won't quite perform the interrupted actions correctly. I may forget some parts of it. I may actually double certain actions, or I may be interrupted again and I have to do something else. So there may actually be advantages to not responding to all alarms. So when we have monitor information as part of a patient's clinical record, we can probably reconstruct the events that happened to the patient who was attached to the monitor. We can probably know when a nurse approached this patient. She, for instance, may have pushed the deactivate button on the alarm. Now, if we have this data now in this clinical record, and there is an adverse event, the patient dies, what happens in intensive care units, obviously, the patient or the patient's family, in the case the patient is not alive anymore, may request, and probably will be granted by the court, access to the recordings from the monitor. Now, these recordings will now serve as evidence in legal procedures. If we have a nurse in the intensive care unit who did not respond in a timely manner to the alarms before an adverse event. The staff, or this particular nurse, will probably be held responsible for the consequences of the event. Now, this would be considered in legalese professional negligence by omission by a healthcare provider, okay, which is something which courts treat very severely. And it's very likely that the hospital and the staff will be held responsible for this negative outcome and will have to pay damages. So what will be the likely response of hospital administration when things like this happen? They will probably decide on policies that say you have to respond immediately to a recorded alarm whenever such an alarm happens, because we don't want these records to reflect you not responding to alarms. Okay, so we will have medical staff respond immediately to all indications. And we may actually find that hospital management may implement some quality measures, which are very fashionable, at least in Israeli healthcare systems at the moment, to reflect these immediate responses. Now, the question is this good or bad? And the answer to this question will depend on the relation between the recorded actions and the importance, the clinical importance of the reactions. If the recorded actions, the actions that have to be performed are really the most important actions from a clinical perspective, then this may actually be very good for patients. But if there is actually a low correlation between the importance, clinical importance of actions and their being recorded, then we may find a situation where adding this additional information not only benefits patients, but may actually even hurt them. So just think of the case where the nurse in the neonatal intensive care unit always has to respond to any alarm. Every 4 minutes she has to leave whatever she does, go wherever she has to go, push the button and go back and resume what she's doing. And it's like, this is likely to lead to an increase in mortality in this neonatal intensive care unit. So we have a dilemma here. Collecting more information may be beneficial, but it may also have some negative consequences. And clearly, I'd like to argue that big data in medical settings, and not only there, obviously, is not only just a technical challenge. It is a organizational, societal challenge, legal challenge in this particular case, which we have to solve if we want to make optimal use of these big data. And here I can, from my research perspective, my main challenge, or the challenge I see for people in my field of research, is to try to predict the consequences of the availability of these data on the functioning of the staff, functioning of the organization, and eventually the welfare of the patient. And obviously to do so, we need to develop some models of information used by medical staff, a little bit maybe in line with the models Aviv Mandelbaum presented here, but taking into account individual human behavior as well. So thank you very much.